Thank you very much for having us. We're really pleased to be able to be here, and we're here representing North Bristol NHS Trust. So my name's Sharon Parsons. I'm a specialist occupational therapist in dementia care, and I'm also the dementia trainer for the Trust. And I'm here this morning with my colleague, Nicola Sterling, also an OT. Nicola's had a much more clinical role at North Bristol Trust, but she's taking a short secondment out to look at meaningful interaction through purposeful activity, meaningful activity. So she's going to be talking to you a little bit about her project. Nicola's been in the Trust for a number of years. I've been there 9 months, so I'm on quite a learning curve still myself. But we've had a great fun working together and thinking about how the digital reminiscence system can be used at North Bristol Trust. We're just going to tell you a little bit about the history of North Bristol Trust. So around the turn of the century, there are 4 main hospitals in North Bristol. There was Frenchay, Glenside, Blackberry Hill and Southmead. And Blackberry Hill was really the place where most of the dementia care was provided. And then it was moved over to Frenchay Hospital. And as hospitals do, they amalgamate, they separate, they merge, they divide. So over the course of the last 10 years or so, all our services have gradually moved onto the Southmead site, onto a brand new bespoke building, which I'll tell you a little bit about. But we're now currently the largest NHS trust in the southwest of England, and we're a major trauma centre for the southwest. So the Brunel building, this beautiful purpose-built building, as you can see on the slide there, it's very large and it's an amazing environment to work in. But as you can imagine, it creates lots of issues for caring for different needs in different clinical settings. So at the heart of the building is the very large atrium. It's a large public concourse, and a lot of public space happens there. There's arts events, there's access to all the services, it's a meeting place, there are cafes. It's a very thriving space. It doesn't feel like a hospital at all, and lots of people say, actually, it feels like an airport. You can see on the picture there, so the 3 fingers that are protruding, that's where the ward spaces are. So they're on one side of the atrium. And on the other side, there are some other buildings you can just see in the picture. That's what we would call our clinical corridor. So that's where all our services are. And they're not really for public access. You have to have a swipe to get in there. So it's designed so that patients can flow through the space easily. They don't get lost down corridors and dead ends. But the staff, hopefully, we don't carry and transport patients through the public spaces on trolleys and things like that. So we separate the clinical work from the public face of the hospital. It's about 280 metres long, the atrium, which actually equates to about 2 Wembley football pitches, just to give you a sense of the scale. And on a map we have the average length of time it can take to walk down the atrium could be 10 to 15 minutes, depending on your speed of walking. We do have a little trolley bus that travels along the length for people who haven't got great mobility or need to get to clinics at the far end of the atrium. But it gives you a sense of the scale of what we're working in. It really doesn't feel like a hospital, as a traditional hospital would have felt like. And significantly, for older people who don't have recent memories, who are working from their older memories, it's not a hospital at all to them. It's a very alien environment. But for staff, it's very lovely. We also have our own robot porters. These cause quite a lot of amusement for us. So they're programmed, they transport around the place on their own, and they're used mainly to carry services like laundry and food. And they only really work in the clinical corridors, but they're quite entertaining if you come into them, in contact with them. So our wards are actually located on something called gates, again reinforcing the airport principle here. And the idea of a gate is that it provides access to other spaces. So when you arrive at gate 28, you arrive at gate 28A and B, and those are wards A and wards B. So they're actually public spaces as well, and gathering spaces, and you can see here staff use them for informal conversations, meetings. There's Nicola actually there in her OT role. And that's Lou, one of the ward sisters, having a catch-up with her staff there. And we also hold our memory cafe here, which I'll tell you about in a minute. We have 23 inpatient wards, and that provides 800 beds. So 600 of those are in single rooms. One of the new initiatives is that most of our patient care is provided in single rooms, which younger people love. They like their Wi-Fi, they've got their devices, they've got their time, their privacy, their family can come in there, and it's brilliant. and it's not so great for older people, is it? It's not what they really need. They need contact and community. But we also have 184 beds in 46 bays. So as you go into the ward, on the left of the door is a 4-bedded bay, and on the right of the door is a 4-bedded bay, and one's for ladies and one's for gentlemen. So we have a little bit of bay cohort nursing, but there's only 8 beds per ward that can provide that. And we employ around 7,000 staff. So just to give you a little context of what the dementia team is, there's 2.5 of us. So Dr. Judy Howarth is our clinical lead. She works part-time for us, and she used to run the memory service in South Gloucestershire. She's recently retired from that now. She just works for us. And my colleague Jet O'Neill over on the left there, the right there, she's the dementia matron. She's been a ward sister and manager for many years in the trust, so she knows the trust very well. And as you know, I'm Sharon. And just to tell you a tiny bit about the service, we have a cognitive bundle that we roll out across all the wards. So we use This Is Me from the Alzheimer's Society, and we really try to bespoke the care that we provide for dementia care, in addition to all the other clinical care needs that people come with. And we run a memory cafe in association with the Alzheimer's Society every Wednesday afternoon, which is a resource place and a centre for anybody, so families, staff, carers, volunteers, to come and just ask questions, get some advice, take some leaflets away, or just have a chat and meet up with us. And we were lucky to be highly commended in the BMJ Awards last year for Team of the Year for our collaboration with the Alzheimer's Society. And I think we're running one of the first memory cafes in a hospital rather than in a community setting. And as I've said, this beautiful room, this beautiful building does create problems for caring for older people. And the statistic nationally is that around 1/4 of all hospital beds have some people in them with cognitive impairment. So for us, the average then is about 200 of our beds will have somebody with some cognitive needs. So that does create challenges for us. It means that people are at increased risk of isolation. There is an increased risk of falls and serious injuries. There's an increased risk of disorientation and delirium, and an increased risk of length of stay and complex discharges, all because of the complexity of caring for older people, where we may be not able to respond to their needs as quickly, or they try to do more things on their own without support. And so in order to mitigate some of these risks, we were working on 3 initiatives last year particularly. So we worked on a 90-day enhanced care project, looking particularly at making best use of our one-to-one or enhanced care approach, so that we don't just put an agency nurse into care for somebody, but we really skill the ward staff up to do really good bespoke enhanced care. And we will use agency staff if required in other parts of the ward. We were involved in a sign-up to safety programme, particularly around reducing risks of falls, using sensors in the rooms and on the beds, but also skilling staff up with a dedicated falls trainer to work on all the wards, not just do lecture theatre training, but do patient-related training. And the dementia team were involved in the Dementia Action Alliance environmental improvements following the audit that we carried out, because we had a brand new building, but it was a blank canvas and we needed to bespoke it and make it dementia friendly. So we were working on lots of things. We were buying pictures. There was not a clock in the building. Now, how disorientating is that if you're already a little bit disorientated? So we put clocks in all the rooms. We bought some Bradford beam chairs to put in corridors and public pathways, because again, there was no seating for frailer older people to sit down while they were walking. So we did a few environmental projects as well. And as part of that, then, we purchased our first 2 DRTS systems. We purchased them through a charity hospital bid that we were able to successfully win. And we put one on a complex care ward, which was Nicola's ward, and we put one on an acute neuro ward. And everyone said it's brilliant. And the overall message was, can we have one, please? We want one as well, because people were starting to see how effective they were being. So in 2015, just last year, we bought 13 more systems with tablets as well, and that we've been rolling across all the wards and providing training. And Fiona's been coming to us many times to do additional training, which we've really appreciated. But Nicola and I feel we've come full circle a little bit as occupational therapists. The whole route of where our profession has come from is in purposeful activity in a hospital setting, and it often started in post-war rehabilitation. And at Glenside Hospital, which is now University of West of England, I saw this archive display and I thought, how interesting. The archive said the hospital was run as a self-sufficient community, but when the NHS took over, patients were often left with nothing constructive to do. And in 1957, Dr. Donald Early collaborated with local businessmen to employ patients in assembling pens and other small things that could be sold, so brought purposeful activity back into convalescence and rehabilitation. And an immediate change in patients was visible, and socialising was more cordial. So it's just interesting, isn't it? You can't separate recovery from healthcare from doing. So being is so interconnected with what you do. And this article really influenced me in my early career as a dementia specialist OT. They did this study where they observed the quality of patient-staff interactions. And they noticed that there were very low levels of patient-staff quality interaction outside of expected routines of care. We're good at washing and dressing, put your dress on, put your arm in here, but when the task had been finished, there was no more conversation or interaction. And at no time did staff engage in patients in social activities or prolonged informal conversations. It was the task alone that was the focus. And yet 306 nurses ranked talking to patients as enjoyable, important, rewarding, and an objective of their work. What they believed about their role was not what they were doing. And there was a huge discrepancy. And the article, the report concluded that the needs of the institution was given greater importance than those of the patients that they were there to serve. And communications that focus on specific tasks to be carried out, taking the form of instructions and statements, do not form the basis of social interaction. And I think our belief in the importance of meaningful social interaction through doing, through purposeful activity, is really the core of what we believe. And Nicola's going to come and tell you a little bit about the project that she's been running on.